Various studies have highlighted how using 1% atropine eye drops is the most effective in controlling eye growth and myopia progression. However, more patients have reported experiencing side effects such as photophobia, irritation and pain in the eyes, blurred near vision, and watery or dry eyes. In response to this, studies have been conducted on lower concentrations of atropine and their effectiveness. Our group article was a longitudinal and interventional study evaluating the effectiveness of 0.01% and 0.02% atropine eye drops on spherical equivalent refractive error, axial length, accommodative amplitude, and the pupil diameter of myopic children. These measurements were chosen as atropine relaxes the ciliary muscles associated with accommodation, allowing individuals to focus on distant objects. A section of the article which may bring forth some difficulties in understanding was that atropine is a non-selective antagonist of mucineric acetylcholine receptors. Atropine is a non-selective drug which acts on more than just one receptor without activating them. The ciliary body and iris sphincter express 5 mucineric receptor subtypes, where the M3 subtype is the most predominant. Parasympathetic stimulation of these causes various eye functions such as accommodation and contraction of the iris sphincter muscle. While the use of atropine is effective against controlling myopia progression, the mechanism of action is still unclear and requires further research.
In the study, 400 right eyes of Han nationality children who visited the first affiliated hospital of Zhengzhou University were recruited between June 2016 and June 2017. The inclusion criteria was children aged 6 to 14 with low or moderate myopia and no other eye diseases or previous surgery. The exclusion criteria was previous use of other myopia control methods and inability to comply with study schedule. The atropine groups were assigned in a double-blind randomized way to either 0.01% or 0.02%. The study followed the principles of the Declaration of Helsinki. All children were prescribed full-time single-vision spectacle correction with the least negative power. Children in the treatment groups applied 1 drop of atropine to both eyes once before bed. At each follow-up, 3 measurements of pupil diameter, accommodative amplitude, axial length, and SER were taken, and the average of each was recorded. Visits were conducted 1, 4, 8, and 12 months after initial treatment. To measure pupil diameter, autorefraction was used. Accommodative amplitude was measured monocularly using the push-up technique. Corneal power, anterior chamber depth, and axial length were measured using a non-contact partial coherence interferometer. SER was measured using cycloplegic autorefraction. Discomfort symptoms were assessed using a paper quiz at each visit, asking subjects about frequency and severity of photophobia, blurred near vision, and other ocular irritation. A t-test was used to compare the 1-month data with baseline to determine if there was an initial hyperopic shift. A generalized additive mix model was used to estimate the trend in SER, axial length, pupil diameter, and accommodative amplitude over time. All statistical analyses used Empower and R.
By the end of the 1-year study, there was a difference in spherical equivalent between the atropine groups and the control. The rate of spherical equivalent progression in that year was significant in all 3 groups, with the control group having the steepest rate of progression. The trends are similar with the measured axial length over time, with 0.02% atropine group having the reduced rate of progression compared to 0.01% and control. A significant decrease in accommodative amplitude between atropine and control groups was reported, as well as a significant increase in pupil diameter. 23% of the 0.02% atropine group and 24% of the 0.01% atropine group experienced photophobia under bright sunlight only. However, there was no significant difference in pupil diameter between photophobia and non-photophobia groups.
Varying concentration of atropine did have an effect on the progression of myopia in children. From the results obtained, it is made clear that the 0.02% concentration of atropine was more effective than the 0.01% concentration in controlling myopia progression over a 12-month period. However, with both concentrations, change in pupil diameter and accommodative amplitude were similar. From the study conducted, 400 myopic children were used and divided into 3 groups. The small sample size reduces the reliability of the study as it does not represent a large cross-section of the myopic population. In order to improve the reliability of the study, a large sample size, 1,000 plus people, should be used. The repeated measures at 4, 8, and 12 months increases the reliability of the study. The initial myopic prescriptions of the people in the study were not given. Thus, this could reduce the validity. This indicates that there is more than one independent variable. In order to improve the validity, all variables need to be controlled to ensure that the results obtained are only due to the changing concentrations of atropine and not any other factor. Myopic individuals could be categorized with different powers and then be compared. It is important to categorize individuals who are more similar together, as there may be factors such as genetics and lifestyle which could impact on the results. Hence, such variables impact the results and reduce the validity of the study.
There are discrepancies via several factors from other studies. At first, there are different doses of atropine in different studies from 0.001% to 0.05%. Second, the age can change in pupil diameter and accommodative amplitude. The young age group was a small change in the results than the other older groups. Third, atropine efficacy varies with race related to melanin levels within the areas. Caucasian are likely to be greater pupil size and accommodation change than Asian with the same atropine doses. Atropine is non-selective antagonist of muscarinic acetylcholine receptors in terms of M3. Increased pupil size can cause photophobia, and the reduction of accommodative amplitude is related to blurred linear vision.
Limitations are the features of the design or method that could impact the interpretation of the research findings. With respect to our study, we found that it did not contain any selection bias. However, the study did contain some sampling bias, since it was only conducted in one region. Although all participants were selected within the same demographic and clinical parameters using the same inclusion criteria, it did not reflect the general population of myopes. It also did not contain a sufficient sample size for statistical measurement, which could not be concluded as a valid research. Only 400 participants were involved, which did not ensure the sample is representative of a population and statistical results to be generalized to a larger population of myopes. Therefore, the sample size should be larger to further improve reliability, accuracy, and validity. Lastly, the study did not contain measurements of pupil responsiveness. This is associated with photophobia and should be considered in future atropine trials to confirm the present findings. On the other hand, however, the study did contain a sufficient amount of research on the topic as cited and referenced throughout, which indicated that prior studies provided the theoretical foundation for the current study, and also did not contain any conflict of interest arising from cultural bias and other personal issues.